Welcome back to part 2 of a 3-part series on neurological emergencies. We're going to pick up right where we left off here with seizures. So a neurological episode caused by a surge of electrical activity in the brain. Right? This can take the form of a convulsion or can be associated with a temporary alteration in consciousness. So 2 basic groups, generalized seizures and partial or focal seizures. The generalized seizure results from abnormal electrical discharges from large areas of the brain. Typically, this is characterized by unconsciousness and a generalized severe twitching of all muscles, usually lasting several minutes or longer. This may be simply characterized by a brief lapse of consciousness, and it doesn't involve any changes in motor activity. In a partial seizure, there's no changes in the patient's level of consciousness. They may have numbness, weakness, dizziness, visual changes, or unusual senses of smell or taste. They may have some twitching or brief paralysis, but it's usually not significant. In a partial seizure, complex partial seizure, altered mental status occurs. This results from abnormal discharges from the temporal lobe of the brain. Lip smacking, eye blinking, associated jerking, unpleasant smells or visual hallucinations, uncontrollable fear, repetitive physical behavior. So the seizure can be accompanied by an aura. Patients may experience an aura prior to the seizure, and that can include visual changes or hallucinations. People with a history of seizures recognize their auras and usually take steps to minimize injury. Auras do not occur prior to every seizure, and not all patients with a seizure disorder exhibit an aura. In a generalized seizure, this is characterized by a sudden loss of consciousness, chaotic muscle movement and tone, as well as apnea. They may exhibit bilateral muscle movement characterized by a cycle of muscle rigidity and relaxation. Usually lasts longer than 3 minutes, but they're saying between 1 and 3 minutes. Generalized seizures include tachycardia, hyperventilation, sweating, intense salivation. Most seizures last between 3 to 5 minutes. What we call the post-ictal state lasts between 50 and 20 minutes. And again, that can be well beyond a half an hour, depending on the severity of the seizure. Absent seizures are usually called petit mal seizures, and they may last for just a few seconds. Patient fully recovers with a brief lapse of memory. Status epilepticus, and this is probably what we should be most concerned with, are seizures that last more than 5 minutes and they're likely to progress to status epilepticus. Seizures that continue every few minutes without a person regaining consciousness or they last longer than 30 minutes are referred to as status epilepticus. So some seizure disorders are congenital, others are caused by high fever, structural problems in the brain, or metabolic or chemical problems. So probably the kind that we see, usually the patients are resolved, the seizures are resolved prior to our arrival, especially if they're some sort of congenital disorder or maybe from a tumor. The seizures that we see that we get to treat in the field are usually the status epilepticus, because their seizures are prolonged. And as an EMT, so what do? We manage their airway, we give them oxygen, we keep them safe from harming themselves. And on the ALS level, the paramedic can carry drugs to stop the seizure. And the other one that we would probably get commonly called to would be febrile seizures, and we see that a lot in children. So epileptic seizures usually can be controlled by medications, and this is just a list of medications. I'm not going to go in through it, so you can pause your screen and read them. Seizures may be caused by an abnormal area in the brain, and we would call that a structural cause, right? So they maybe have a tumor, an infection, or scar tissue from some sort of another injury. Seizures from a metabolic cause can result from abnormal levels of chemicals in the blood, low blood sugar, poisons, drug overdoses, sudden withdrawal from routine heavy alcohol or sedatives, prescribed medications. Seizures can also result from sudden high fevers, right? Especially in children. So we have to recognize seizures. And when we're recognizing a seizure is occurring and whether the episode differs from previous ones, they may turn cyanotic from a lack of oxygen, right? Because they're not breathing effectively. Seizures may prevent the patient from breathing normally. In a patient with diabetes, the blood glucose level might decrease. The muscle actions in a seizure create a lot of energy usage in the body, which decreases the blood glucose levels. If our protocols allow, monitor their blood glucose, and our protocols do allow, so we can do that. And then we need to look at some other problems that are associated with the seizure. Patients who have fallen during a seizure may also have a head injury. Patients having a generalized seizure may also experience incontinence, and that would be the loss of their control over their bowels or their urine. So, post-ictal state. After a seizure, the muscles relax. They become almost flaccid. Breathing becomes labored. This breathing pattern helps the body balance the acidity in the bloodstream, so we're returning to homeostasis. With normal circulation and liver function, the patient will begin to breathe more normally in minutes. This might be characterized by hemiparesis, resembling a stroke, so they may lose function over one side of their body or the other. It's most commonly characterized by general lethargy and confusion. They can become combative. Be prepared for all of these things. If the patient's condition does not improve, consider hypoglycemia or infection. So syncope. Seizures are often mistaken for syncope or fainting. Fainting typically occurs when the patient's standing. Seizures may occur in any position. Fainting is not associated with a post-ictal state. Altered mental status. Aside from stroke and seizures, the most common neurologic emergency. Patients not thinking clearly or they are incapable of being aroused is another sign of the altered mental status. In some cases, the patient will be unconscious. In others, the patient may be alert but confused. In hypoglycemia, as a cause of altered mental status, we may see that the patients have signs and symptoms that mimic a stroke or seizure, right? They might have hemiparesis. One side of the body is not working over the other. A patient who has had a stroke may be alert and attempting to communicate. A patient with hypoglycemia almost always has an altered level of consciousness. Oh, can you guys see that on the screen? I just realized I have a pointer. Oh yeah, that's cool. So, hypoglycemia. Patients commonly take medications that lower their blood glucose level. Patients can also experience seizures. The mental status is not likely to improve even after several minutes. So we're going to consider hypoglycemia in a patient who has altered mental status after an injury, such as a motor vehicle crash. Delirium, a symptom, not a disease, right? So this presents as a new complaint, temporary state that may have a physical or mental cause, such as infection, changes in medication, hypoxia. Another common thing we see with delirium is from drug overdoses, right? So you may have heard of people taking things like bath salts or a lot of those synthetic marijuanas cause excited delirium, right? And that's something that we can treat as well. But also, we need to be very cautious, as we do with any of these altered mental status patients, because we don't know the cause, we don't know how they're going to react, we don't know how they're going to behave. So remember, we always have to maintain our own situational awareness with all of these patients because their conditions can change quickly. So, other causes of altered mental status, again, AMS is altered mental status in this case, Consideration of other possibilities become important because a patient with altered mental status may be combative. They might refuse treatment and transport. If they have altered mental status, they cannot refuse treatment and transport. In most cases, the patient who appears intoxicated is usually just that. But we need to check vital signs, blood sugar, all those things, and ask the important questions. Physiological disorders and medication complications are possible causes. Infections, particularly those involving the brain or the bloodstream, can cause altered mental status. So, scene Sizeup. Let's talk about that. Scene safety is important, right? Dispatcher may be able to provide us with the description of the patient's problem. They might not be able to. Patients with altered mental status may exhibit a wide range of signs, symptoms, and behaviors. Do not be distracted by the seriousness of the situation or frighten family members. Sometimes that can be the hardest thing, right? When you have a family member screaming that you're not doing something or not doing it the right way. You just always rely on your training and always do the right thing for the patient. You're never going to go wrong in that situation. Consider the need for spinal immobilization. So, mechanism of injury, nature of illness. Look for clues to determine which this falls under. Is this a nature of illness? Is this a mechanism of injury? Special considerations for a patient with suspected neurologic emergency, right, calls for an evaluation of the environment for signs and symptoms of potential trauma, indications of a previous medical condition, evidence of a seizure. We need to ask the family, when was the last time they appeared normal? And we need to know time, right? So when was the last time they appeared normal? An hour ago. That's not going to cut it, because an hour ago to them can be different than an hour ago to me. If I tell you an hour ago, it could have been a couple days. So we want to get a time. Was it at 8 o'clock in the morning? Was it at 8:30, 8:15, 8:27? Be specific. In our assessment, we're looking for life-threatening conditions, and we want to treat them. So we're doing a rapid exam. Gather information from the scene. What do we see? What's going on around us? What's the environment look like? Note where the patient is and where their body's positioned and their level of consciousness. Our initial impression is going to help us determine the severity of the situation. So we should be able to tell if a seizure took place. Are they on the floor? Is the stuff on the floor around them scattered? Does it look like they were shaking or convulsing? Use our AVPU scale. In our primary assessment, right, we're going over airway and breathing. Patients may have a hard time swallowing. They may choke on their own spit or saliva. So be prepared to suction these patients. Position the patient to prevent aspiration. Check for foreign body obstruction. Remove it if necessary. Assess the patient's breathing. All patients with an altered mental status, regardless of the cause, should receive high flow oxygen. Ventilate them, right? If they need to be ventilated, ventilate them. Deliver each breath during a period of 1 second at a rate of 10 to 12 breaths per minute. That's on the test. Do not hyperventilate the patient. Hyperventilation can have negative consequences. We could decrease their cardiac output. We can risk regurgitation and aspiration from filling their stomach up with air, and further injury to the brain in patients with intracerebral bleeding, and increased intracranial pressure. So sometimes too much oxygen is a bad thing, or in this case, not blowing off enough carbon dioxide. So circulation, check the pulse. Is it present? Is the patient unresponsive? Do they have a pulse? If no pulse is found, immediately begin CPR and attach an AED. If the patient is responsive, determine if the pulse is fast or slow, weak or strong. Evaluate the patient quickly for external bleeding. And then we need to make a transport decision. So how are we going to do that? Are we going to transport rapidly? And again, this is based on our assessment, our level of consciousness, are ABCs. If the patient is experiencing a stroke, we need to transport them quickly to the most appropriate facility. I think I skipped a slide. So in our history taking, we're going to investigate the chief complaint. For unresponsive patients, we're going to gather history from family or bystanders. I think this is where I'm going to pause, and I'm going to go into chapter 2 or part 3. So this is the end of part 2. We're going to start back up with history taking here, and we're going to wrap up neurological emergencies. I hope you're enjoying it so far. Catch yourself a little bit of a break.